Jaundice. Definition of jaundice. Jaundice disease, also known as icterus, is a yellowish discoloration of the skin, conjunctival membranes over the sclera and other mucous membranes caused by elevated levels of bilirubin in the blood. The normal level of bilirubin is below 1.2 mg/dl. When the level of bilirubin exceeds more than 2.5-3 mg/dl, it leads into jaundice. Jaundice, also known as icterus, is a yellowish or greenish pigmentation of the skin and whites of the eyes due to high bilirubin levels. Jaundice in adults is typically a sign indicating the presence of an underlying diseases involving abnormal heme metabolism, liver dysfunction, or biliary tract obstruction. Normal heme metabolism. The reticuloendothelial system, RAS, removes immune complexes from the circulation in healthy persons, and is formed of phagocytic cells that are found in the circulation and in tissues. The RAS encompasses monocytes of the blood, macrophages in connective tissue, lymphoid organs, bone marrow, bone, liver, and lung. NADH is nicotinamide adenine dinucleotide phosphate hydrogen. Jaundice is typically caused by an underlying pathological process that occurs at some point along the normal physiological pathway heme metabolism. A deeper understanding of the anatomical flow of normal heme metabolism is essential to appreciate the importance of prehepatic, hepatic, and posthepatic categories. Thus, an anatomical approach to heme metabolism precedes a discussion of the pathophysiology of jaundice. Prehepatic metabolism. When red blood cells complete their lifespan of approximately 120 days, or if they are damaged, they rupture as they pass through the reticuloendothelial system and cell content including hemoglobin is released into circulation. Macrophages phagocytose free hemoglobin and split them into heme and globin. Two reactions then take place with the heme molecule. The first oxidation reaction is catalyzed by the microsomal enzyme heme oxygenase and results in biliverdin, green color pigment, iron, and carbon monoxide. The next step is the reduction of biliverdin to a yellow color tetrapyrrole pigment called bilirubin by cytosolic enzyme biliverdin reductase. This bilirubin is unconjugated, free, or indirect bilirubin. Approximately 4 mg of bilirubin per kilogram of blood is produced each day. The majority of this bilirubin comes from the breakdown of heme from expired red blood cells in the process just described. Approximately 20% comes from other heme sources, however, including ineffective erythropoiesis, and the breakdown of other heme-containing proteins, such as muscle myoglobin and cytochromes. The unconjugated bilirubin then travels to the liver through the bloodstream. Because this bilirubin is not soluble, it is transported through the blood bound to serum albumin. Hepatic metabolism. Once unconjugated bilirubin arrives in the liver, a liver enzyme UDP-glucuronyl transferase conjugates bilirubin plus glucuronic acid bilirubin diglucuronide, conjugated bilirubin. Bilirubin that has been conjugated by the liver is water-soluble and excreted into the gallbladder. Posthepatic metabolism. Bilirubin enters the intestinal tract via bile. In the intestinal tract, bilirubin is converted into urobilinogen by symbiotic intestinal bacteria. Most urobilinogen is converted into stercobilinogen and further oxidized into stercobilin. Stercobilin is excreted via feces, giving stool its characteristic brown coloration. A small portion of urobilinogen is reabsorbed back into the gastrointestinal cells. Most reabsorbed urobilinogen undergoes hepatobiliary recirculation. A smaller portion of reabsorbed urobilinogen is filtrated into the kidneys. In the urine, urobilinogen is converted to urobilin, which gives urine its characteristic yellow color. Causes. The causes of the jaundice are usually classified on based up the dysfunction of the normal metabolism or excretion of bilirubin. The disruption in the metabolism of bilirubin can occur at various stages. Depend upon the stages of dysfunction, the causes of jaundice are divided into three ways. Prehepatic. Hepatocellular. Post-hepatic. 1. Prehepatic. The pathology is occurring outside of liver. An infection or medical condition destruct the red blood cells sooner than usual and increased level of bilirubin such as sickle cell anemia, malaria, thalassemia, hereditary spherocytosis, drugs or other toxins, Gilbert's syndrome, autoimmune disease, hemolytic uremic syndrome, glucose 6-phosphate dehydrogenase deficiency, G6PD. 2. Hepatocellular. The problems are mainly occurred in liver. When the liver is damaged, it loses function in the metabolism and or excretion of bilirubin. Acute or chronic hepatitis, commonly viral, hepatitis A, B, C, D, E. Alcoholic liver disease, liver cirrhosis, glandular fever, paracetamol overdose or toxicity, drug-induced hepatitis, Crigler-Najjar syndrome, alcoholic fatty disease, illegal drug use. 3. Post-hepatic. The problem is located after the conjunction of bilirubin in the liver caused due to obstruction of biliary passage, gallbladder stones, cancer in the gallbladder, pancreas or bile duct, biliary atresia, cholangiocarcinoma, pancreatitis, parasites, like liver flukes, cholestasis of pregnancy, pancreatic pseudocysts, Mirazi's syndrome. Risk factors. There are various types of risk factors for jaundice disease, which are mentioned in the following: heavy consumption of alcohol, pancreatitis, hepatitis B/C, liver cirrhosis, thalassemia, hereditary spherocytosis. Sign and symptoms. There are different types of sign and symptoms for jaundice disease. Those are mentioned in the below: yellow color of skin, sclera of eye and mucous membrane of mouth and nose, dark colored urine, skin itching, nausea and vomiting, pale colored stool, fever and chills, stomach pain, weight loss, loss of appetite, diarrhea, weakness, confusion, headache, swelling of leg and abdomen. Diagnostic evaluation. There are different types of test and diagnosis for jaundice. Those are mentioned in the following: history taking, physical examination, liver function test, complete blood test, urinalysis, electrolytes panel, conjugated or unconjugated bilirubin, USG of hepatobiliary system, CT scan or MRI, ERCP, endoscopic retrograde cholangiopancreatography, percutaneous Tun's hepatic cholangiography, liver biopsy. Management. The treatment depends upon the underlying cause and how serious it is. Watchful waiting and home rest. For supportive treatment may need various medications such as painkiller, antibiotics, antiviral, steroids etc. Antiemetic medicine for controlling nausea or vomiting. For fluids in cases of dehydration. Chemotherapy, radiation therapy. If the cause is genetic such as sickle cell anemia, thalassemia, a blood transfusion may be needed. If any drugs make toxicity, these must be discontinued. Surgical or various invasive procedures may need to treat jaundice, such as laparoscopic cholecystectomy, removal of gallbladder stones or bile duct blockage, liver transplant, resectability of neoplastic causes of biliary obstruction. Nursing management. There are different types of nursing intervention for jaundice disease. Those are discussed in the following: assess color of skin, sclera of eye and mucous membrane of mouth and nose for every 8 hours. Check for anything for complication and notify to physician. Check neurological status 8 hourly to identify complication of bilirubin encephalopathy. Check vital signs every 4 hourly. Monitor intake output and check urine and stool color. Administer medication as order. Control of nausea and vomiting and administer antiemetic drug as order. Monitor direct and indirect bilirubin to evaluate treatment efficacy. Provide healthy diet, consult with dietitian. Give mouth care to increase appetite and prevent vomiting and provide low-fat diet. Encourage patient to take plenty of fluid, at least 6 to 8 glass daily. Check weight daily to evaluate weight loss or gain. Administer for fluid if diarrhea present. Ensure proper rest and keep everything reaches to patient. Keep skin clean and dry to prevent itching. Provide health education to patient and patient party how to prevent jaundice. Arrange vaccination program and administer vaccine to patient as order. Provide psychological support to patient and encourage patient express feeling. Complication. There are different types of complication for jaundice disease, those are mentioned in the below. Electrolytes imbalance, anemia, chronic hepatitis, cancer, bleeding, liver failure, acute bilirubin encephalopathy, conjunctival, kidney failure, death. Prevention. Various types of prevention ways for jaundice disease are described in the below. Cessation of alcoholism, alcoholic hepatitis, cirrhosis, and pancreatitis. Maintain healthy weight and avoid extra buttery food and fast food. Having a healthy and balanced diet. Avoid coffee, tea, hot spices and red chili. Avoid stress as much as possible. Avoid potentially roadside and contaminated food, water, and maintain good hygiene. Hepatitis A. Take vaccines against hepatitis, hepatitis A, hepatitis B. Aware details information about the country and take medications which prevent malaria before traveling to high-risk regions. Avoid illegal behaviors such as intravenous drug use or unprotected intercourse. Hepatitis B. Avoid medications that can cause hemolysis in susceptible individuals, such as those with G6PD deficiency, a condition that leads to red blood cell breakdown after consumption of certain substances. Avoid medications and toxins which can cause hemolysis or directly damage the liver.